My name's Kel Heyl, and I'm doing a series on Forum called Pushback Storytelling. When you're on death's doorstep, do you want to suffer, wait for a miracle, or end your life peacefully? My next guest will be Senator Christine Eaton. We'll talk about her bill, the Minnesota End-of-Life Option Act. In 1972, my grandfather Carruthers was diagnosed with amyotrophic lateral sclerosis, ALS, Lou Gehrig's disease, a death sentence. Stephen Hawking may have lived with it for 55 years, but for my mother's father, he died 15 months after the diagnosis. When Grammy died, Grampy's condition fell off the cliff. He was taken to live with Aunt Berta's family. My cousin Paul was his personal care assistant. During the summer, when they went on vacation, I was his PCA, helping him use the toilet, take a shower, shaving and dressing him. At this point, he could walk, but his arms were useless. 9 months later, he was admitted to Easton Hospital in Pennsylvania to die. Given a shortage of nurses at the time, my mother and her two sisters were taking turns caring for him. I was on summer break from St. Olaf, and I said I would sit with Grampy so they could have a rest. I had no idea what to say. He was having difficulty speaking. I didn't have a clue how to engage a person 55 years older. Given his love of sports, I decided to tell him about playing rugby during spring term. Looking back, I took the easy way out. I tried to be a distraction. A few days after I told Lawrence Bates about playing left lock in a rugby scrum, he died. ALS patients tend to die from suffocation. The muscles that make us breathe stop working. One of the most profound experiences of my late adolescence was digging the grave for his ashes. Sometime later, after 2 different conversations, my mother told me her father had asked her to kill him. The first time, would she push him down a long, steep flight of stairs? The second, would she turn off the ventilator? Both times, she refused. How would Grampy's end of life been if there was the possibility of medical aid in dying? My guest today is Christine Eaton. She represents Brooklyn Park and Brooklyn Center in the Minnesota Senate. She's a registered nurse. She's one of the political leaders who's been at the forefront of working to lessen opioid overdosing. She's the author of the Minnesota End-of-Life Options Act. For me, her bill is pushing back against needless suffering. Senator Eaton, thank you for being my guest today.
Thank you for inviting me.
It's hard to estimate, but there's perhaps millions, if not billions, of problems or challenges or opportunities you could sponsor legislation to solve or engage or birth. Why did you decide on suffering at the end of life?
Well, my experience as a nurse and being a patient-centered care nurse, I just was frustrated with watching people suffer at the end of their life and having the doctors or the government make all those decisions. I can make decisions at the end of life up until the point where I'm dying. And then it's taken out of my hands, and I didn't think that was fair. I think that if we want to go through the disease process, and a lot of it isn't very pleasant at the end, that should be a choice. I don't think suffering really is of all that much value when it's pain and you're going to be dying.
One of the things that I was thinking about as I was getting ready for this show was the people who are opposed to this, I'm wondering if their assumption is that if somebody's suffering at the end of life, and some people believe suffering is noble,
Right.
is it a question of if some suffering is a certain level of nobility, more suffering is even more noble, and even more suffering after that is more noble, so we shouldn't intercede because the person is busy being noble. And one of the things that I'd like to do today, if I understand correctly, is Oregon, that has had death with dignity in place for over 2 decades, they have a form that the patient fills out and is an agreement between that individual who's terminal and suffering and their physician. And although in your bill you have verbiage for Minnesota, I'd just like to draw on this as a structure for some conversation to explain to people what the relationship is and the safeguards that are in place so that there's a fear that people are going to be forced into this. And I just want to be able to convey the safeguards. So just in the beginning here, one of the key things is that people have to affirm their condition.
Correct. They need to have a diagnosis from their doctor or a prognosis of 6 months to live, and they need to be 18 years of age, and they need to be able to make medical decisions.
And if I understand correctly, the key professional role here is of usually the physician, who has to make a judgment that yes, indeed, this person it's highly likely that within 6 months this person will die.
Correct.
And that they are competent to make judgments concerning this agreement.
Correct. And I also included in my bill, which is not in Oregon's bill, that advanced practice nurses can participate.
There's so much going on now in litigation where people who claim a certain religious belief want to not participate in these things. So if I'm a physician and I don't want you to terminate your life voluntarily, what happens then?
You have no obligation to participate, and there's actually language in my bill that guarantees that you don't have to. And we just request that you transfer the records and help the patient find another doctor. That's considered standard practice for any doctor who no longer wants to work with a patient, rather than abandoning them.
And as far as informed consent, when the physician is in agreement that this is a possibility for this individual, what sorts of things does the patient have to be informed about as far as alternatives to taking a lot of medication and bringing on death? What are other alternatives for somebody at the end of life?
Well, I added into my bill another thing that Oregon doesn't have is that they're mandated to have a referral to hospice. They're not required to go, but they must have a referral. The doctor must tell them about palliative care and the advantages of hospice and if the issue is pain, other methods of finding pain relief. They can change their mind at any time, that once they fill the prescription and have the medication to take to end their lives, they cannot take it.
It's not a people mover.
Right.
But you don't get on one end and then you start out living at one end and at the other end you fall over dead. That's not what we're talking about.
Right. You can change your mind at any time, and it's up to the person when they take it. You know, many people, including one of the first that I became familiar with, who became a mover and shaker in the, anyway, she got the medication and she lived almost 7 months before she was reached the point of where she just couldn't take it anymore. She was having seizures, Brittany Menard, and she was having seizures like all day long, and when they ended, she wouldn't be able to see or hear sometimes, and she couldn't verbalize, and then she would come back and be able to communicate, but she never knew when the next seizure was going to come, and she never knew if she was going to come back again. And it was exhausting and demoralizing, and she just decided that she'd had enough. And so I believe it was November 1st that she had planned on taking the medication in October, but she...
So a number of things to sort of draw out a little bit. Would you talk a little bit about what hospice is?
Hospice is a program that we have, and we have an excellent one in Minnesota, whereas someone who has a terminal diagnosis, and their requirement is the same as my bill, 6 months prognosis, and then you get all kinds of services. You can get a nurse, you get someone who comes in if you're unable to bathe yourself, or any kind of help with your medications. And one of the big problems we have in Minnesota is people don't access it soon enough. Average use is about 7 days.
And how do people access the service?
Through their doctor or through their insurance. I know my mother had hospice. She had to have a renewal. She lived almost a year on hospice. And it was such a gift for our family because they coordinate the care. They help you find answers to concerns that you might have. She kept falling, so they helped us find a type of walker with a tray she could carry her stuff on that actually worked in our house because she wanted to stay home. And they had a nurse that came in and managed her medication, and it was wonderful. And people don't utilize that enough.
And would you talk a little bit about palliative care?
Palliative care is usually medication. Sometimes it's massage. Sometimes it's acupuncture. Whatever works to make somebody more comfortable. And it's people use it outside of hospice. You don't have to be terminal to have palliative care. It's used for people with back problems or whatever. We're constantly encouraging people to use the latest technology, and I mean, there's medical devices that work. Unfortunately, a lot of insurance companies won't cover them. It's cheaper to cover a pill, and acupuncture can work really well for a lot of people for pain, but again, you have to fight your insurance company often.
But this would normally be the treatment that ensues from the relationship between a healthcare provider, a physician, say, and the patient, and they would work together, and this kind of care would be occurring in that setting. Exactly.
And in fact, in my opioid legislation work, I've worked with we added education for the doctors on palliative care and on pain management, because that's part of the problem with the opioid epidemic is doctors only, with the 15-minute appointments maximum, it was a prescription for an opioid was the go-to answer.
Easy.
Yeah.
Easy.
And developing a plan of care for pain takes up much more time and is much more work intensive. So it wasn't encouraged by a lot of HMOs.
Now, one of the things that impresses me about the Oregon form, and this is the form that a person who is terminally ill, this form is used to specify the agreement between, say, a physician or, in your bill, a nurse, and the individual. And one of the things that impresses me about the Oregon bill is down at the bottom, they list the rules of the game as to who can, because when the person signs this, it has to be witnessed.
Right.
It's not just an oral agreement that was said at 11:30 at night when somebody was half asleep. This is a written agreement, and one of the things that intrigued me about Oregon is, as I say, the rules of the game. One of the witnesses can't be a relative. They can't be a part of the person's estate.
Right.
They cannot own or operate or be employed at the healthcare facility where the person is. So one of the things that impresses me about this piece of paper is right here, it's building in safeguards so that the person's choice is as clear as possible, unambiguous, this is what I want to do.
Right, and that's why those conditions are in my bill also.
Because the concern is that somebody knows they're about to inherit $1.5 million, and they're just whispering in this person's ear day after day. So these are building firewalls between that possibility.
And that's why I require self-administration, and that's why Oregon does, well, in fact, all of the different states that have it do, because I haven't found a way that I'm comfortable with that somebody else could administer the medication without risking abuse of that exact situation.
So now what I'd like to talk about is the actual steps that lead to death. So would you walk us through the medication, the way it can be ingested, and who does the physical act of preparing and administering the chemicals which bring on death? Would you walk us through that?
Certainly. Well, the first requirement, which you've brought up, is you must make a written request for the that you want to participate in the end of life procedure, and then the doctor confirms that you have the diagnosis and then the prognosis, and that you're competent, and that you're an adult of 18, and that you have a referral to hospice, or you are in hospice. And 97% of the people in Oregon are in hospice, but most of them end up using this at home with their families. So the next step is 15 days later, you need to re-request. And then the doctor goes over all the other alternatives again and says, you know, you can change your mind at any point. You can withdraw this. There are these other options available. And then if the person wants to continue and they've, in between there, they've had a second, you have to have a referral to a second doctor. I almost forgot that. And if that second doctor needs to confirm that all these things are in place. And if they think that there's a mental health issue, that the person is suicidal or depressed, or that they're being coerced or anything, they disagree with any of that, then you have to go to a mental health professional and have an assessment.
And just to be clear, is this the way Oregon operates and the way your bill would operate?
Yes, they're both the same. And so once you've been cleared by the second doctor, then the 15 days from the first request has to take place. And as I said, they go through the reminder of all the alternatives, and the making sure that they've been in touch with hospice if they haven't. They don't have to, though. The next thing is that the doctor would discuss the medication with them, and would recommend that they would use it not in public. That's something that we don't want to distress the public. It's something that should be a private ceremony or a private event, and explains the medication and the effects and what to expect. You're given a medication so that you don't immediately throw up the medication, because it's caustic, it's hard on your stomach, and you're told that it's bitter, that it's going to taste bitter, and that you'll need someone, or you'll need to, depends on what level of you're at the time that you decide to use this. It's a lot of capsules, and it's barbiturates, and you have to take them apart and dump the insides into a container, and then you mix them with something. A lot of them use Gatorade or juice or whatever, and make a slurry out of it. And then, and it doesn't, I mean, if you can't do it, you can have your friend or whatever, as long as the person who is the one who takes it.
Mm-hmm.
And sometimes it might be to the point, especially with ALS, where it's somebody hands you a cup with a straw in it. Mm-hmm. That might be the best you can do, is mm-hmm. to use a straw. And I've heard talk that that they think that legally it would qualify if you could put it in your tube feeding, okay. But I don't know for sure. That would have to be something that I guess if it came up, you'd have to check it out, because I don't know. But so the person would take the medication that would prevent them from, or would help them keep the medicine down. And then when they took the medication, it would make them tired and they would fall asleep eventually, and eventually it would stop the diaphragm from, stop you from breathing. So it would be a peaceful falling asleep and stop breathing in your sleep. So most people, it happens within an hour or two. There have been people who it's taken longer, but not known of anybody it didn't work for. There's no pain, no discomfort. The biggest thing they say is that it's going to taste very bitter, so you should have something to drink afterwards so that you can cleanse your palate or whatever.
Yes, there's a group, Death with Dignity, and I was impressed that they made all those recommendations of have something that's sweeter after you take this. What's the best argument you've heard against this?
I guess I haven't heard one I guess the best argument I've heard is if this is against your religious beliefs, you should not do it. And I agree. I mean,
that's leaving it on the shoulders of the individual.
Right. Nobody can be mandated to do this or participate. No home care aide, no nurse, no doctor, no HMO. Nobody can be mandated to do this. It's voluntary for everybody. And some of the concerns initially were that there would be like just one doctor who'd be willing to do this, and we'd have doctor death or something. But that's not been the case. They have 200-300 doctors participating in Oregon, and in other states that's proven to be true also.
What's the status of your bill?
My bill in the Senate is kind of dead on arrival. I continue to go around doing my best to bring it to people's attention. They did have a hearing in the House. I had a hearing in 2014, and in the Health and Human Services Committee. We pulled it and did not do a vote. I was pretty sure I didn't have the votes and didn't see any advantage to a negative vote. So I'm hoping that the Senate goes back into the Democratic majority in 2020 and that the House remains in the Democratic majority. I'm pretty confident the governor will sign it if we pass it. So I'm hoping in 2021 we can get this through. But
if people want to read the bill, where can they go to see it, the draft?
They can go on the website for the Minnesota Senate, and the bill number is Senate File 2286, and its companion is in the House. I don't know if I know the number of the House. I don't. But Representative Mike Freiberg has the House version.
And if people want to work with you to get this passed, how can they get in touch with you?
They can contact my office. I have a very open door. I'm in 2403 in the Senate building. And
I like that building.
It is nice. And, come and see me. I have an open door. I think one of the things that disappoints me the most is that I don't hear from a lot of constituents or from people. People don't bother to contact their legislators very often. And so when somebody does, it's much more impactful than you would think, because not that many people do.
Senator Eaton, thank you for being my guest today. You can post comments, questions, suggest topics or guests for future shows on the Affirming Flame Facebook page. That's the Affirming Flame. Thank you for joining us today. I hope you'll reflect or pray on your end of life and how you'd like it to be. I'm Kel Heyl.